Colleen, what about new interventions for prevention in the antiviral space? What are we looking at?
I think I mentioned this before, but it's such an exciting time because there are so many other options that are kind of in the pipeline for people for prevention. And I think at some point, right now we have one FDA-approved biomedical prevention intervention, which is Truvada for PrEP. But at some point we may have a suitcase, and people can pick and choose what's going to work best for them, work best for their situation and their lifestyle. And I think that's where we need to get as a field with HIV prevention. And so there, I think, are three things to mention. One is a ring, which is an NNRTI formulated ring that women insert into the vagina every month, and I think they're looking at longer formulations of that as well to prevent HIV infection. And this was shown to be efficacious in women in Africa, although maybe not as efficacious as we would have liked. But this is the first, or one of the first women controlled prevention interventions where there's no condom negotiation, there's no power struggles. A woman can control her prevention or HIV prevention desires. And then also in clinical trials is injectable cabotegravir that we already mentioned that is in trials for treatment, is also in trials for prevention. And right now there's a very large head-to-head study that's being conducted by the HPTN, the HIV Prevention Trials Network, where injectable cabotegravir every 8 weeks is being compared head-to-head with oral Truvada for PrEP. And we think and we hope that cabotegravir will be as effective as Truvada for prevention. Unfortunately, it's a very long study, and so we were not going to have results for many years to come. Right. Because Truvada is so effective, those head-to-head trials are hard to do and take a long time, but hopefully we will have a good result, and that will be available for folks down the road. And then finally, I think some very exciting things with monoclonal antibodies that are directed against HIV that are being looked at as prevention agents, either as infusions, potentially subcutaneous injections, potentially even down the road implantable type devices that could be used for PrEP in the future in the absence of an effective vaccine. And I think those are all very exciting things that we're going to be hearing a lot more about.
Sure. Certainly, even cabotegravir injectable, this challenge there is with adherence, to have something that could be given once every 2 months. And if it turns out that it is similar to tenofovir emtricitabine, would really be an advance for yes. some people, I think. Mm-hmm. And one of the challenges of the studies, of course, is that since you have to compare it to a pill, then it has to be people that can take a pill.
That's right.
But you could imagine like women in vulnerable situations or people that really can't navigate, taking pills, that intervention would really change things. I
yeah, and it's much more conducive to a kind of a public health approach sure. and deployment of a prevention intervention if you have something that's injectable and long-lasting, mm-hmm. That you can reach many more people very quickly for long periods of time. Yeah. So.
The other things that are being looked at, and we've sort of alluded to them, maybe not quite as transformative or sexy, is one is whether we could use TAF as an alternative to TDF.
Study.
And the other one that you alluded to also was on-demand PrEP. I don't know what your thoughts are about that.
Yeah, so on-demand PrEP, meaning taken around the time of sexual activity, was shown to be highly efficacious in a study, in a clinical trial done in MSM, or men who have sex with men in France and Canada. It works, and the regimen is taking 2 pills before sex, and then 1 pill 24 hours later, and then another pill 24 hours after that. And it is effective. I think it's not recommended in the US, and I don't recommend it either, mostly because the folks I see have a hard time understanding their risk and their risk behavior. I think this was a very selective population of incredibly high-risk people, in high-risk men in France and Canada who are very good at judging their sexual risk and realized that they are at risk and knew that what they were engaging in that weekend was going to put them at risk. And I don't see those people in my clinical practice very often. Occasionally I do, but I think in a more generalized epidemic setting, which is what my experience is in the Southeast, I don't think we're ready for that yet, but it is effective.
Yeah, I mean, I guess the other issue is for the primary analysis is that they were so high risk
They
that
took
they were
so many
taking
doses.
so much. They were almost, they were taking more than 4 doses a week on average in this MSM population. And I know they did a post hoc analysis in a subset of individuals that didn't take it as often, and it continues to look efficacious.
It does. And so I think that argument doesn't really hold up anymore. It does look to be effective even in those people that don't take 4 doses a week. So it works. It's just, I think we have to be very careful about who we identify as being appropriate candidates for on-demand dosing.